Hello, am I in the SMA room now?
You are, welcome. Hello, Dr. Sanders, how are you?
A little bit awkward to get back. I'm like, I'm actually meant to be talking.
No, okay, well, I'll do an introduction quickly. So good afternoon, everyone. I'm Charlotte Sangster. I'm the CEO of Muscular Dystrophy New South Wales. I'm going to be your moderator. So I'll just do a quick introduction. If you think that you're in the wrong room for this session, you can press the leave button at the bottom and Alicia will put you in the right room from the main session there. And just for Zoom hygiene, I'll ask that we all remain on mute. It's up to you if you want to keep your camera on, but as long as we're all muted, that means we'll be able to hear Dr. Sanders speak really clearly. Just as by way of introduction, now there's a lot of long words in here, so hopefully I don't stutter. Dr. Lauren Sanders is an academic and clinical neurologist at St Vincents Hospital, Melbourne, with expertise in stroke, headache and neuromuscular conditions. Dr. Sanders is an investigator on a number of neurology clinical trials and has a particular interest in improving pathways of care. So she sits on several advisory committees and is currently undertaking work to improve the transition to adult health services for young adults with neuromuscular conditions, including Duchenne, FSHD, SMA, CMT, and many other conditions. Dr. Sanders is a senior lecturer for the Department of Medical Education at the University of Melbourne, holds a grad dip in clinical education and is currently undertaking the Master of Clinical Education. So we are super lucky to have you. Thank you so much. The presentation will be for 25 minutes. Respectfully, Dr. Sanders, I will give you a 5-minute warning.
Perfect.
And then we'll have 15 minutes for questions. You can put your questions into the chat box at any time. So at the bottom of your screen, you'll see a little box that says chat there. I'll then go through those at the end. If we run out of time, unfortunately, we may not be able to get to all questions, but please do pop them in the chat box so then we can try and get through them all. And otherwise, yeah, the presentation is recorded. It will be on our website, and I believe Dr. Sanders will share her slides. So yeah, thank you. I'll let you commence.
Okay, so thank you very much for that introduction. I'm hoping you can see my screen in the appropriate view at the moment. Should have my title slide there. Okay, I'm really honoured to be speaking with people today. I'm really excited about this. And I'd like to start by acknowledging the traditional owners of the land where I work, live and am presenting from today. And that's the Wurundjeri people of the Kulin Nation. So I'm presenting from Melbourne this morning, and that's the closest that any of us are going to get to New South Wales for quite some time, as I assume, by the looks of it. We don't have a lot of people in the group, so if you've got questions throughout, please wave at me or put your hand up or put something in the chat and I'll stop. And we can answer questions as we go. Michelle is an absolute guru in this, so Michelle, if I get anything wrong, just jump in and correct me. But I'm actually going to focus on the updates for treatments in adults with SMA today. Okay. All right, I do have a couple of relevant disclosures, and in that is that I am currently working on a couple of advisory boards with both Biogen, and I'm about to start doing some work with Roche, who do make medication for spinal muscular atrophy, and I'm paid to be on those advisory boards. Some of the data and the slides with the graphics that I'm using today have been provided to me by those companies, but I'm using an independent approach to using that data. Okay, so what I'm going to go through in the next 20 minutes is an overview of how the treatments that we have available now for SMA work. How do we know that they work? How well do they work? And then I'm sure, as everybody wants to know, when are they actually going to be available for us in adult SMA? So I do want to go back just a little bit to the actual gene, because it's really important that we understand how and why these medications are working. So in our genetic makeup, we have chromosomes, and we have 23 pairs of those chromosomes, and they come from our parents. So it's one set of chromosomes from mum and one set from dad. And so each parent contributes one set of those, and then they come together to make up our DNA. And those genes are then just transcribed or translated into messengers that allow an unwinding of the genetic coding or makeup, which goes on to create the proteins. So when we're thinking about the relevance of genes in SMA, those pieces of DNA that are called SMN1 and SMN2 are the ones that are relevant for us. And SMN stands for survival motor neuron. So these are the genes that ultimately translate into the makeup of a protein. And the challenge that we have with SMA is that something's gone wrong with that particular gene in chromosome 5. And you'll often see in genetic testing reports that it might say SMA 5q13. So what that means is that it's on chromosome 5, on the long arm of the chromosome, which is Q arm. So we've got a short arm and a long arm, and it's at region 13, so they divide it all up. So that's just telling us exactly where on the chromosome the problem has happened. Some people who had genetic testing with the older terminology might see SMNT or SMNC on their genetic reports, and that refers to whereabouts the gene is located. So we have the telomere, which is at the end, and then the centromere. So T means it's closer to here, and C means it's closer to the centromere. So that's the terminology of it. When we look at the way that the genes actually translate into making a protein, the SMN1 gene is the one that's really responsible for the majority of the protein. And so in DNA, we have different regions called exons and introns. And in preparation for making the proteins, there's this process that we call splicing. And this is where the in-between bits, or the introns, which are these little grey bars in here, are cut out, and they leave behind the exons, which are the coloured squares. Those exons ultimately squash together, and they translate then into a full-length protein, which is really important for muscle function in our day-to-day activities. We have a backup gene though, which is SMN2, but in the coding at exon 7, there's one letter difference in the coding sequence, and that means that sometimes exon 7 is excluded from this process. So we've got missing exon 7, and that means the ultimate protein isn't quite as stable as it should be. So it rapidly breaks down and isn't as useful, which is why we see muscle problems in SMA. Depending on the number of copies and where exactly the problem is, you can get variable amounts of the full-length protein expressed. So this becomes important when we start thinking about how nusinersen works. So nusinersen is a bit of a mouthful, and it's an antisense oligonucleotide, or ASO, and it's basically a synthetic fragment of DNA. And that binds to the SMN2 pre-RNA to increase that inclusion of exon 7. So if you sort of think about it, you can just see here, this is our, oh sorry, wrong screen, SMN2 gene. Here's our problem at exon 7. We don't want this to be left out. And so the nusinersen binds, and it's like we've got some scissors coming in, but the medication allows for that intron to be protected, and so we don't get the intron being cut out. Ultimately, that leads to an increase in the SMN protein production. And so there are lots of other approaches at the moment that are trying to really, I guess, exploit our understanding of this underlying genetic mechanism. And so we have lots of different approaches, and we've heard Michelle speak about some of them this morning. So the adeno-associated viral vector, or AAV9 SMN, is looking at that viral vector to bring the repair into the system, and we can see that that's the picture of it there. So that comes in, and the gene replacement allows for some correction in that whole process. And so there is an open label study going on in Belgium, which I understand was completed in September. There's also a couple of studies in Japan and the USA that are looking at this particular approach. The one that people are probably most familiar with at the moment is RG7916, which is actually risdiplam. And so that is a smaller molecule which is centrally, so brain, and peripherally, so outside of the central nervous system, so it acts in both of those places, and that's the one that's orally available. And this other coding you can see here, the LMI070, is a similar concept. with that, and that's Branaplam, which is Novartis medication, and there's currently some open label trials in type 1 SMA going on for this as well. And so these are smaller molecules that look at targeting that exon 7 splicing. There are a couple of other things that are currently in clinical trials as well, but I'll just focus on the ones that we are more readily getting access to for adults at the moment. So how do we know that these medications actually work? So we can measure the increase in the SMN2 messenger RNA. We can look at measuring an increase in the SMN protein. So are we actually getting an N protein with increased protein? We can examine people who have SMA having the treatments, and perhaps most importantly, we can ask the people being treated. So these are some of the results that have come out of the studies looking at nusinersen. So this is a slide that's been given to me by Biogen. And in the clinical trials, we talk about a primary endpoint, which is what is the key thing that we're really interested in understanding for this particular study. And then there are secondary endpoints. So these are things that we might look at that are not the key outcome we're of interest, but something else we'd like to know about. And so the primary endpoint in a lot of these clinical trials is the Hammersmith Functional Motor Scale score, and looking at that across several months throughout the study. The revised upper limb module, which is this one here. So I've got two screens and I keep pointing to the wrong screen with my cursor. Is often a secondary endpoint, and the 6-minute walk test, which is how far can you walk in meters over 6 minutes for people who are still walking. And then often they'll do a subgroup analysis in the studies, and this looks at, well, what is there a difference between the outcomes and the effectiveness of this medication for people with SMA2 versus SMA3? What about people who can still walk versus people who are now using wheelchairs for mobility? And there's also now an increased interest in looking at lung function with these medications. So one of the exciting articles that was published in the Lancet this year, which is a really prestigious journal in medicine, was this one looking at nusinersen in adults. And this was an observational study, which means that everybody had the medication and they followed those people to see how they were doing with the outcome. So this was conducted across Germany in a number of centres, and it was looking at the Hammersmith motor score, the 6-minute walk test, and the revised upper limb module. And so this particular study gave people a loading dose at the beginning and then followed those people across up to 14 months. And so the average age of treatment initiation when people started treatment in this study was mid to late 30s. So this is a really representative adult population, and around 2/3 of the participants in this study had SMA type 3 and 2/3 were unable to walk at the onset of the study. And so the changes in the Hammersmith score were what we were really interested here, and anything that's greater than 3 is considered a significant clinical improvement, so something that we would really notice if we were examining people. And so you can see that over time the benefit continued to improve. So at 6 months, 28% of people had a 3-point improvement or more. That rose to 35% at 10 months, and then when we got out to 14 months, 40% of people had at least a 3-point improvement on that motor score. This slide shows the number of patients who showed improvements in their 6-minute walk test over time. And so along the bottom here, we see bars that are representative of each individual in the study. So at 6 months, the data are representative of 47 participants. And along the side here, we've got the change from the way they started at. So if you went up, it meant you could walk more meters, and if it went down, it meant you were walking less meters than when you started. And so what we can see here is that the majority of people actually started walking more, and on average, people were walking 22 meters more than when they started. What's important to note is that when we got out to 14 months, the difference was 46 meters. So that's quite significant. I just note that there's a chat come through. Okay. So we might come to salbutamol at the end as well. Okay, if we've got time. Now, looking at 46 metres, I paced this out in our corridor. So from where I've taken the photo to the very end of the corridor, that's 46 metres. And so that's on average how much people were able to walk as an improvement from their baseline. So as I mentioned, the 3-point improvement is considered a clinical meaningful change, but 1 to 2 point increase could still be clinically meaningful to a person, particularly if it means that you haven't actually declined over time, which is what we would expect the natural history to be, is a very slow decline over time. And importantly, when they looked at the safety of nusinersen in adult patients, they found that it was really well tolerated, and that's certainly our experience that we're seeing talking to my colleagues, and what we've seen here at St. Vincent's in adults with nusinersen is very well tolerated. Not surprisingly, as it is given through a lumbar puncture, that you can get a headache, which is a complication of lumbar puncture in general. Some people had some back pain, and some people have nausea, but we really haven't run into a lot of trouble with that to date. Moving on to risdiplam, so a lot of these data are very recent and early. There hasn't really been to date a lot that's been published for this. I did get a couple of updates from Roche yesterday, which I'm not allowed to show you the slides, but I'm allowed to talk to it. So the risdiplam are the fish studies. So they all called fish. So there's FIREFISH, SUNFISH, jewelfish, and rainbow fish. So the two that have data available at the moment are FIREFISH and SUNFISH, and I'm going to talk a little bit about those as well. Jewelfish is an open label study, which means that everybody knows what they're getting. And that's in people from 6 months old to 60 years old. But all of those people in that study have previously been treated with some kind of an experimental treatment for SMA. And they have completed that recruitment, but the results aren't available yet. The rainbow fish is looking at babies who have a genetic diagnosis of SMA but who don't have symptoms yet. And that's currently recruiting. So the FIREFISH looks at babies with type 1 SMA, and they firstly looked at the safety and the dosing, and then they went on to look at the effectiveness. And the overall results of that showed a significant increase in milestones at 12 months of treatment. The SUNFISH is the one that included some adult population. So I think 14 adults aged 18 to 25 were included in that study who actually got the medication. And that was what we would consider one of our gold standard methodologies, where there was a double blind, so neither the patient nor the clinician knew if they were getting the medication, and it was placebo controlled, so the drug was compared to the dummy drug. And that included people with type 2 or type 3 SMA, and that study did meet its endpoint, which we'll go into now. So these are some of the results from FIREFISH. So there were 41 babies included in this study, and they found a significant improvement in both motor function on the validated assessment scores and in the milestones that were achieved for those babies. They also found an improvement in survival compared to the natural history of what we would have expected. And really important finding from this study was that only about half of these babies needed to attend hospital for care over that 12 months. And so in the first year or so of life, staying out of hospital is a really great achievement. They found that around 29% were able to sit for more than 5 seconds by the end of the study, and 93% of these babies were alive after 12 months. And as many of you would know, in type 1 SMA, we often lose these babies very early on. And the natural history studies would suggest that the median survival is around 10 months. So 93% still with us after 12 months is really exciting. But moving to adult neurology, which is a little bit more up my alley. So the SUNFISH Part 2 results were released in June this year. And so this study was a two-part study. It was, as I said, double-blinded and placebo-controlled, including people with type 2 or non-ambulant, so not able to walk, type 3 SMA. And in this study, people had between 2 and 4 copies of the SMN2 gene, and most of them had 3 copies. Importantly, there were no drug-related side effects that led to withdrawal, which is really good to know, although there were some side effects, and that's to be expected because this medication is an oral medication. It gets out into more parts of the body, so there's more opportunity for it to cause some side effects. So around half of people had a fever, a cough occurred in 35%, vomiting, upper respiratory tract infections, and sore throat. What they found in this particular study is that the motor function measure scores either improved or stabilised. And when they looked at the subgroup analysis of those aged 18 to 25, around 60% of people were stable at the end of the study versus just under 40% of the people in that age group who received the placebo. They also measured an increase in the SMN protein in this study and found that there was a doubling of the protein at around 4 weeks, although we're not really sure what that means clinically. And importantly, they also looked at the SMA independence scale, which is a patient-reported outcome measure, and found an improvement in activities of daily living. So just to end on that before we go into some question time, we've mentioned briefly today the Australian Neuromuscular Diseases Registry, and this is something that's really important for us in Australia. So at the moment, this registry collects data from people with Duchenne muscular dystrophy, SMA, FSHD, and myotonic dystrophy. And when drug companies are coming to Australia to see whether or not they're going to offer their clinical trials, they want to know how many people in Australia have this condition. And we don't know unless we have those data. And registry data also gives us a really great way of understanding how effective we're being in our clinical practice. So it's a really nice way of being accountable for the outcomes and the best practice care for our patients as well. So that's a bit of a whirlwind tour of what's going on in SMA. I'm happy to take questions, and I think there have been a few come through in the chat, which I'll have a look at now.
Are you happy to look at the questions, Dr. Sanders, or there's just a few there?
Yep.
Yeah. I'll leave you to it if you've got it under control.
I've got myself in, I've got so much going on with, I've got the 2 screens. Hang on, let's just go to the chat and I'll put it over here. Yeah. That's better. All right. So let's just go. Okay, I might start at the bottom. So the side effects, things that people with SMA are more likely to get in general, yes, especially the upper respiratory tract infections. That's true, but what we need to look at is the difference in the side effect profile for people who are on the drug versus those who weren't on the drug. So for SUNFISH, most of those were actually pretty well balanced. Slightly less fever, I'm just having a look at the actual table now, so slightly less in the way of fever and headache for the placebo group. There really was a significant increase in diarrhea with this medication, which again is not unexpected given that it's absorbed via the gut. And then a couple of the other infections that we're seeing, so influenza, was seen more commonly, but it was really only 2 patients versus 0. So whether that's statistically significant or not is difficult to know. And then, so Michelle is coming, so a neurologist for the first time. Yes, absolutely. These medications need to be monitored really carefully because not only do we at the moment have almost 0 data in the safety and effectiveness in adults, we don't have any long-term data because they're new. And so it really needs to be monitored by somebody who understands the condition. So these drugs often are available first through tertiary centres who have neuromuscular clinics, because that's where the concentration of expertise is. So what we would recommend is that people would get a referral to a neurologist who specialises in the area, and then go from there. Okay. Right. Just trying to make my chat box bigger so I can read things properly. Yeah, so we're still trying to understand the benefit in terms of severity and how much we expect people to improve with medications. And we're certainly seeing really dramatic changes in type 1 SMA, and that it is taking a bit longer in type 2 and type 3. And certainly when I've heard some of the experts from Germany speaking to their experience with patients from watching their observational studies in Germany, that it does seem to take longer to see a benefit in type 3 than in than what we were seeing in the other studies. Yeah, so a couple of questions coming through about Celebrex and salbutamol. I'm not routinely using that for my adult population or recommending it. Michelle, I don't know whether you want to talk to that as well.
Yeah, so there are some studies that suggest salbutamol can work, and I think it's like a poor cousin to nusinersen. It can have some upregulation of SMN2, but it's not major, and I think it was more in use before nusinersen was around in the pediatric clinic. It also, there have been some studies out of Holland looking at the junction between the nerve and the muscle, and it can actually help the way the nerve talks to the muscle. It's called neuromuscular junction, and there's some studies that are special electrical tests showing it can improve it. So a couple of my young kids with SMA type 3 wanted to do it, and the study suggested it might help, and really I talked to the parents. I said it might help with fatigue, and that's what they thought would be very meaningful for them. But we talked about the side effects, particularly tremor, because, you know, people with SMA already have tremor, and if it makes it worse, it can actually interfere with your ability to use your hands. And another side effect is salbutamol's fast heart. I think, you know, it's an individual choice. I think it could give us very small benefit, but if that is something that's positive, but it's safe and you can tolerate it, I think you just have to talk with your doctor about it.
I think in the adult population, we have more concerns around using long-term Celebrex, in particular because of the risk of gastrointestinal side effects and kidney problems as well. And then in salbutamol, it can cause some disturbances of the potassium levels as well. And in adults, that's more likely to give us a bit of grief as well. So we haven't been routinely looking at that at the moment.
Yeah, I've never used Celebrex.
In fact, with my other hat on, I'm a stroke physician. I'm constantly trying to get people off Celebrex as well. So just the long-term non-steroidal use is not great for the gut, and certainly not great for the kidneys. So there've been no head-to-head studies on Spinraza or Risdiplam for type 3, so we don't know which is going to be better, or if they're the similar effectiveness or not.
Were there any more questions? We've still got about 15 minutes left.
Yeah. I did have a couple of other discussion points that I was wanting to go through. So I'm currently on an advisory board where the adult neurologists in Australia are trying to come up with a consensus approach so that no matter which adult centre you go to around Australia, you're going to get the same treatment for your SMA. And so that we're all consistent and that we're all actually aware of best practice evidence and we're putting it into place. And I'm interested to know what people in this breakout room think about some of these topics. So the first thing that we've been discussing is that there's a bit of a shift in the terminology that's being used now, away from saying type 1, type 2, type 3, and talking about sitters, non-sitters, and walkers. And so I'm interested in what people think about that change. We're probably going to start using both. What do people think about sitter, non-sitter as a terminology? Any thoughts? Maybe just, we've got a small group, we can probably just unmute. Is that all right, Charlotte?
Yep. Yeah, I think we can keep that under control.
Yeah.
I don't think that either kind of are awesome, because I'm apparently, you know, it's supposed to be a sliding scale. I don't quite sit, I definitely don't sit 3. I'm somewhere between 1, but I lived, so I'm very low function. So yeah, it's that sliding scale sort of situation. Yeah. So it's really hard to put it in boxes.
Yeah. I think it's something that will continually evolve over the years. Any other thoughts on the terminology?
I kind of agree with what Christy said as well. I think it's just another way to kind of put us in boxes from an outside perspective when our condition is, you know, internal neurological condition.
Yeah, like me and Julie both have the exact same SMA, but it affects us in different ways. So.
Exactly.
So I think the way that it's probably going to be used in that terminology is that there's going to be a set of guidelines of if you do fall into that box of maybe being a sitter, what should we be doing when you come to see us in the clinic? The words just, I don't know, they just grate a bit on me. So I was interested to see what people thought. The other things that are being discussed are a standardisation of assessments. So typically in an adult neurology clinic, we don't do a lot of these scores, the Hammersmith or the revised upper limb module. What sort of the historical reason behind it is that it wouldn't change our clinical practice a lot of times. And the thoughts from neurologists, particularly before we started talking to our patients enough, was that it was kind of depressing to come in and have a score every time that might just be a little bit lower than last time, so we just didn't do it. So I'm interested in people's thoughts on if we start doing standardised assessments. Is this something that you're interested in? Is this something that you're prepared to spend the time in? Certainly if we have treatments, we'll have to do it.
Sorry, I think Sharon's just accidentally shared her screen. You might need to take that back over, Dr. Sanders.
I think a way of standardized testing, it may, you know, it may not make a big impact in, you know, clinical, I mean, it might or it might not, but if you look at it as a more holistic sort of thing, so if we have like a better standardized test for, say, NDIS, you know, it might become more recognized. So, you know, it might help in a whole range of things, because right now we fall under what's called HUDAS, and it's I don't know, it just doesn't quite fit well. So, you know, if we start to get more standardized assessments, it just might help with things like that as well.
Yeah, it's something that I would be keen to see. I think also when you have that standardized approach to it, it focuses your mindset around making sure you are addressing the whole person as they come in as well. One of the challenges of the revised upper limb module or the 6-minute walk test is that it actually doesn't take into consideration the impact for that person on their day-to-day living and, importantly, quality of life measures. And so one of the things that we're currently discussing is, should we be routinely looking at patient-reported outcomes that do cover degree of independence, which is obviously not something that's measurable by clinical examination in the consultation. You know, should we be asking people about how well they can get dressed and watching that? What about how well you can get to and from work, or use public transport, or all of those things, or go out to a movie independently. All of those sorts of things, and whether that should be a routine part of our clinical reviews when we see people. Any thought?
Yeah, I definitely think that that is going to be more important to us, you know, as the consumer.
Yeah.
But I do also understand how it's so important for all of you in the medical realm to really back up and have those boxes ticked off with those standardized testing as well.
I think, again, it's going to be a nice conversation point. I mean, I'll often go through my list of things with people and ask, what's your list of things that we need to get through in the clinic appointment today? I think having those standardized things means that we are more likely to be providing best practice care. What about the duration of clinic appointments? You know, if we're going to be doing more thorough assessments and more thorough evaluations, it's going to take longer. So I'm interested in what people think about the duration and the frequency of assessments. Patricia, did you have a comment for that?
Oh, sorry, somebody's speaking to me, sorry.
Did you have a comment?
No, not a comment. I was actually just typing a message to you. I'm the mother of 2 SMAs, and one, referring to your remarks, a sitting son and a non-sitting daughter, a walking daughter. And they live very full lives. My son in the wheelchair has always used a wheelchair. He never walked. 33. My daughter can walk with short distances, can't do stairs, can't run at 35, but they live very full, reasonably healthy lives. I worry and concern where I live very much in a remote area of New South Wales. Should they be hooked into any kind of system? I remember somebody there saying testing should be, you know, a universal test for SMA, etc. And the thought occurred to me, is there somewhere, other than registering with a neuromuscular condition, is there somewhere that they should be pulling into regularly for any purpose? Like they tend to just get on with their lives and have a very, as I said, respectively, have a very full life each. But is there a point, is there a benefit, is there any reason why they should be hooked into, associated, or I always fear if something was arrived at which would be beneficial to them, nobody knows that they exist really out in their respective areas, you know?
Yeah, and I think that's the really part of it. You know, it's like I go to my GP once a year and get my cholesterol checked and my glucose and all of those kinds of things, and it's a bit of a keep on top of it all. And I think really the same thing applies for people with neuromuscular conditions, that it is worth a touch base with a specialist either every 6 or 12 months, and that's my standard approach, is 6 to 12 months, as a touch base. Is there anything new that we should be doing? Have we got everything under control? For example, in the last couple of years, there's been a lot more attention to paying to monitoring bone health in people who don't walk, because it's not just about fracture risk. There's actually a whole lot of importance about bone health. And, you know, when I was going through medical school doing neuromuscular training, we weren't taught to monitor bone health. So that's actually been quite a big shift. So now we're routinely doing DEXA scans and looking at that and treating proactively with bone health treatments if they're required. So I think there's those things that are shifting, and, you know, the tie-in with allied health when needed. I think also for some people with neuromuscular conditions, if you get sick, it can go pear-shaped pretty quickly. And particularly in rural and remote centres, the local hospitals are much less likely to have an understanding of that condition and what to do if it goes wrong. And if you've got somebody who you've seen once every year or so, then you do have somebody to advocate and advise in those situations. During coronavirus, one of my patients who has Duchenne was COVID positive. And now he is out in the community, he motors around in his wheelchair, he's really, really great. And when he got to hospital, ICU's like, Duchenne, yeah, not coming to ICU if he gets COVID. I'm like, what are you talking about? That's ridiculous. And so we had to really advocate because they didn't understand what Duchenne was.
Just a 5-minute warning for you to wrap up questions, and then we'll have a 10-minute break and get everyone back in the main room for our panel session at 4.
Can I just ask how that young man, is he okay? Like,
yeah, he didn't end up in ICU. I mean, in fact, it's interesting that people who have Duchenne who got COVID, it hasn't seemed to be anywhere near as bad as when the swine flu hit. I don't know of losing anybody with Duchenne in the community. We usually find out. So I don't know whether it's because of the steroid use, it might have been protective. But no, that particular patient certainly is doing well. But it was just, it really hit me in the guts that I had to advocate so strongly. And that's what we're here for, though, because we understand the condition. And I think that's where there's a benefit in being linked in. And, you know, as I mentioned before, these new treatments are going to be available through specialist centres first. That's the way new treatments always come out. If you're linked in with somebody who knows what's coming, you're going to get in first.
Following on from that,
Lauren, can I just, sorry.
Just one question. So Sydney would be our base, and my son actually lives in Sydney. Where would they go to make that connection so that they are, you know, somebody is aware they exist with future treatments and that kind of thing?
So one of your neuromuscular centres, I'm not sure, Michelle, if you know the best place to refer, more across the Melbourne, but I'd say probably Westmead, or where would, any idea, Michelle, if you're still there?
We also have a list of the clinics on our website that you can access.
Terrific. Thanks very much. It's been a very enjoyable afternoon. Thank you very much for your information. I appreciate it.
Thanks. Cara, did you have another question?
Sorry, I was just going to say quickly to your other question, in regards to, I mean, the time frame and that type of thing, what we would be, you know, comfortable with, I think I would be willing to do anything, but it would then just depend on where the centres were, because obviously if we were travelling a couple of hours just to get to the appointment, and then the appointment itself, taking the medication might take 1 to 2 hours, I don't know. So I guess it would just depend on how far we would have to travel to get to those particular centres to take the medication.
Yeah. So, I mean, Nursey Nurse, and you're coming in once every 4 months for a procedure, and what we're trying to do is tee up those appointments with the clinical assessment, so it's sort of all done in one hit.
Yeah.
You know, a standard review appointment at my practice is half an hour. That wouldn't be enough to get through all of the assessments, but it's probably, some of them are probably better done by physios.
Mm-hmm.
And so it might be, you know, 20, 30 minutes with the doctor and then 30 minutes with the physio. So you're there for an hour or so to get everything done.
Sure, sounds good.
All right. Any last minute questions? Because then I think we're up to break. Is that right, Charlotte?
Yeah, we are. So I just want to say a huge thank you, Dr. Sanders. That's been a really informative session, and thanks to everyone for contributing with your questions. I think that's really added another level to the session. Oops, that's my alarm going off telling me to tell you all to go back to the other room. So we're going to have a 10-minute break, and if we can all be back in the main room just before 4 p.m. To hear our lived experience panel. And to get out of this room, you just press leave room in the bottom right corner of your screen. We'll see you back in the main session. Thank you so much.
Thank you.
Just making sure there were no last minute questions.
That was really wonderful. Thank you so much.
You're welcome.
All right, we'll see you back. Are you hanging around, or will we see you back in the main room?
Yeah, I'll hang.
Awesome. All right, we'll see you there.
Bye.